It is not an easy topic to talk about the model of care. And this slide is just to remember that little history. We started to discuss about the model of care, the publication on JCO, it was in 2010, but we started with this project 3-4 years in advance with these people, in particular Karen Britton, that worked in Boston at the time, and the other friend, David Thomas, for Australia. The idea was to try to understand how the different projects that were coming in a different country have difference and similarity, to try to understand the key theme in developing a program dedicated to AYA and what were the barriers. And in that year, it was a little bit complex to start a project, and not many people was really interested in AYA. So we started to think about the concept, about the definition of model of care. What is a model of care? Model of care is an overarching design for the provision of a particular type of healthcare that is shaped by a theoretical basis, evidence-based practice, and defined standard. Thinking that we had to define core elements and principles, but also the framework to provide a structure for implementation and subsequent evaluations. I think this is quite an interesting definition. And then, just to stay on what we did in our experience, we tried to define what were the specificity of AYA in thinking to a model of care. And we already discussed it many times in these 2 days, but this is just to take in mind the most important aspect, that are the AYA are a unique group with special characteristics and special needs. We know well about these, particularly complicated to care for. And AYA are a sort of liminal group of patients, staying in a position at a boundary in transition between the two worlds of adult and pediatrics. And so AYA are at the margins of the existing healthcare service. And both the traditional model of care, the pediatric one and adult ones, poorly address the needs of AYA patients. And we talk later about the needs. AYA patients were, at the time, maybe also today in some places, often the older patients in children's service, or the younger in adult service. And we always say, many times we said in the past, that AYA stay in a no man's land, neither belonging to pediatric nor to the adult worlds of oncology. But on the other side, there was a problem of no man's land, but there was also sort of professional competition for patient ownership. This is something that in some big centers we suffered in the past due to the shortcoming in collaboration between pediatric and adult medical oncology worlds. It is another key point that we try to address in the last year. These are tables quite similar. I put here so you can, when you will take the slide and review, you have time to look at these. In particular, the second table on the right is adapted from the first one that we produced in our centers. Starting from the activity of the youth project, we try to define what are the characteristics of the pediatric model of care and the adult medical model of care. And there are at least 2-3 important characteristics that I want to discuss with you. The pediatric model is usually a family-centered model. The family is in the middle of all the relationship, and often the patients, it is not in the middle, it is the family that is the middle. While in the adult medical oncology model of care, the patients usually have a direct interaction with the doctors, not easy to have in our settings. But the patients in the adult medical oncology model of care is put in a sort of disease-centered model, because the units are often cancer-specific, and this is particular as compared to what happened in our wards, where we were able to create a really multidisciplinary team, involving different specialists, oncologists, surgeons, radiotherapists, but also nurses, teachers, psychologists, educators, and so on. The concept of multidisciplinary in the adult world is a little bit recent, but is a pathology-focused multidisciplinary. That means to have the oncologist, the surgeon, the radiotherapist, and stuff. and stop. And then we have another particular characteristic that is related to the ratio between the staff and the patients. And we can say that in the pediatric model of care, there is a high staff-patient ratio, while there is a lower staff-patient ratio in the adult setting. And this have an impact, have a consequence in the time that the doctor can dedicate to the relationship, to talk, to the communication. We discuss later about this. And this have an important influence on the quality of the care that healthcare providers give to our patients. That we did some years later this exercise that is quite a little bit complicated, but can help to think what we already have in different centers in different countries, in different units. What happened when we try to develop a AYA program? The AYA program may be a specialized program embedded within a pediatric or adult institution. We already have oncology centers, maybe adults or pediatric, and within the centers, we create a sort of AYA subunit or AYA program. This, for example, is what we did in Milan. Then we can have other model. We can have a model where the AYA program is built within different unit within a single city. Or we can have a collaborative network partner model when in a large hospital, usually adults, a AYA program is organized, but then is strongly linked with pediatric hospital, with adult hospital, and so on. Or then on the right, we can have a single program covering multiple sites. And this heterogeneity may be related not only to the strategical and philosophical situation, but also to resources that you can have in the different centers, in the different countries, but also to the different culture you can have. And this is another exercise to try to have a picture of the pediatric model, a picture of the adult model, and the possible picture of the AYA model that can try to take the most positive things above the model. And so you can have a patient-centered model, but the use of really multidisciplinary settings. And in the middle, there is the patient, but not only the patient, but also the patient, the family, the partner, and the friends, and so on. So we say that neither the classic pediatric or adult model of care is ideally suited to meet the needs of patients, but I think that the major question to be seen is whether a single ideal new model of delivery of care should exist, the feasibility of such model, or alternative, what kind of adjustment should be done to one or both the system. At the end, the identification of an ideal model of care is still a challenge. We said a few minutes ago that there are many different models, and the various experience of AYA oncology program developed over the year with difference and similarity continue to generate an interesting heterogeneity of solution. And as I said, reflecting not only an ideal, but also local issue, variation in medical culture, variation in resources. And this is another important point that I think is a little bit changed over the year. 15 years ago, when we worked on this position paper, the situation was different from today. At the time, we say that starting an AYA program was not easy. And we were struggling with a lot of different challenges because few passionate people had a great enthusiasm to try to convince investigators that the proposal was good to be done. But in many cases, a lot of us found a strong opposition, often related to culture, administrative and logistic issue, but also sometimes related to the less will of collaboration between people, because the creation of AYA program was seen sometimes by adult oncology, sometimes by pediatric oncology, as a potential risk to lose some patients. This is a famous position paper we delivered within the ESMO COP AYA working group. You see this many times in these days, but just to say that in the list of the major challenges we have to face in the next years, we put too many areas. One was the access to clinical trials. We already discussed yesterday and we don't need to come back again on this point. But the other point was the definition of the minimal essential requirement for AYA center. That means how to think what is really needed to build the perfect model of care for AYA. And there is a list, you can see here, with the different key themes. And also in JANE, that is the new European network of expertise that will develop in the next year dedicated to AYA, there is a list of the key topics that we need to address. And I try to put together the two different tables, the one from the position paper and the one from JANE, and to try to show you what can be the different aspects that you have to consider when you have to build your AYA program in your centers or in your country. And we say the patient-focused model, of course, the need of multidisciplinary team, the clinical trial availability for all the possible tumor that can arise in this age group, the strong referral pathway and standard of care from many different points of view, clinical, patients, healthcare authority, and so on, the flexibility and emergence of patient age, of course, developing research, of course, space and dedicated project, the psychosocial support, the genetic and genomic testing, the fertility preservation program, the late effects survival service, AYA-specific palliative care service, we discussed, it's a very important point, and then the patient advocacy, of course, that should not be the last one, but it is one of the most important, and then the concept of governance, sustainability, funding. I will try to discuss not all these points, just a couple of these to focus on some specific aspect. First, the concept of patient-focused model and patient advocacy, because we said many times that how is important the concept of promoting normalcy. I really love this paper from the UK, France, that talk about sex, drug, and rock and roll, because we know how it's difficult and how it's different to deal with a child, with an adult, or with an adolescent, because adolescents need to continue to live as normal a life as possible, and so achieving development tasks, living their experience, rite of passage, and so on. And so it's important that the concept of sex, so they need to feel comfortable disclosing sensitive matters, and so talking about sex and drugs. We need to have a non-judgmental relation with them about alcohol and drug exploration, and rock and roll, the lifestyle that really different from that they characterize young people from children and from adults. And so if you want to promote normalcy, we need to consider to build our unit according to this concept. So to have adequate spaces, adequate rules, to, for example, accessible visit time, easy access to the hospital, preserving the need of privacy, but also give them activity and heaven for socializing. And I think that one of the major points is to find a way to give a voice and a choice. Any units, any program, any project dedicated to AYA without the concept of giving voice and a choice to the patients is destined to fail. Many times we as doctors, we try to say what are the needs of our patients, but it's important that we understand that we need to let our patients be the ones who tell us their needs. And it is important that we understand that our patients are not only their tumor, but we have to consider the friends, the family, the career, the spirituality, the learning, the romance, and so on. And this is a possible list of some of the specific needs that we learned from them. Of course, our patient has the needs to receive the best possible chemotherapy, but also the need to be serious. When they need to be serious, they need to play football with their friends. They need to be happy and to be teenagers like the other, but also to shout in fury for what they are happening to them. They need to try to overcome their limits, to think to the futures. They need to think about the beauty and to think about, as we say, the sexuality and romance, and so on. And the other important aspect is the aspect of the multidisciplinary team that should have specific AYA features. And so we say professionals from different clinical disciplines, the importance of having both pediatric and adult medical oncology working together, and to have a specific training. The concept of the staffing is a very important concept, and we discussed many times in these years how we need in practice to build AYA units. You know very well that, as we discussed yesterday with Annalisa Trama, talking about the epidemiology of AYA, if we think to patients from 50 to 39, you have a very different type of tumor. And so how it's possible that a AYA oncologist working in an AYA unit may have the expertise, the protocols for treating breast cancer, melanoma, rhabdomyosarcoma, medulloblastoma, leukemia with equal competence. This is very difficult to be achieved. And so we need to think how we can design units that are designed specifically for young people and staffed by a skilled and multi-professional team expert in both the care of AYA and their disease, and committed to working in a new way. And so how we can try to put together this concept, how we can have a unit that is built by different figures, for example, with this different responsibility, and the expert in melanoma and breast cancer, or the expert on the other side in rhabdomyosarcoma and medulloblastoma, can come when there is the patient with these specific tumors and so on. It is not easy to be understood and to be understood and to be realized. And then when we talk about the involvement of other professionals, there is a long list of the different experts that are really needed, absolutely needed when you need to work with AYA patients. But I want to spend a couple of words also for this. It is not easy to talk about spirituality. It's something that we also speak about palliative care. We also speak about the psychological support. I think it's important also to consider spirituality, because spirituality is a crucial aspect for adolescent and young adult patients. And so it is something that we should consider when we need to have a relationship with them. In our center, we have a spiritual assistant that is a priest that works daily in our unit. It's part of the team. It's not an easy aspect, but it's important because, as we said for the discussion on palliative care, if the patient is used to see the priest or spiritual assistant, if we talk in a not Catholic settings, as part of the unit every day from the beginning, it became easy for our patients to ask to have a talk with them, to ask if they can respond to some specific question of spirituality. And it's very different if the priest arrives in the unit only when there is a bad situation, there is a terminal patients and so on. And this is another important aspect. It's a box in this very nice paper that was written by UK friends. There is a list of the top competencies for healthcare providers that they should have to work with teenagers. And I really like the number 8. They say having time to sit and talk, having time to spend with the young people. This is extremely important not just for psychologists, not just for nurses, not just for spiritual assistants, but just for us, for doctors. And this was an editorial that was called Our Patients Talk and We Learn. I learned a lot from our patient in this year. And I think that this is not a tip, not a response to the question we had in the last minutes after the talk on palliative care, but can be a message to say that we need to learn as doctors that want to work with AYA patients that comes a time where the clinical trial, where our experience, our knowledge are not enough. And there are other things, and you can see here a list, that should be considered, that cannot be linked to others, because sometimes doctors say, yes, okay, but this is just for psychologists, this is just for social workers, this is just for nurses. I think that we as doctors need to understand that it's really, if you want to work with AYA patients, we must bring into play, along with our expertise, all our humanity, our strengths, our weakness, our time. Then there is, of course, the aspect of the space and the project dedicated to them. It's important to have something that is dedicated to our patients. I think that most of the units on EYA have dedicated spaces that can be very different according to the different projects that became the hideout for our patients. That's very important. But I think it's important also to show you this model. Many of you may have the opportunity to see this slide many times, but it is just to say that in our project in Milan, we created the idea to have a creative and artistic project that can involve music, photography, fashion, writing, video production, to give our patients a way to express themselves, looking to the quality not only of the care, but to the quality of the life of our patients. And very rapidly, I want to show you the different meaning, the different reason for this project that give to our patients a great opportunity to get together. For both patients that are receiving treatment and then them that already completed the course of therapy, sharing the time, the difficult time of their treatment with people going through the same experience, and give them time of a moment of normality, of lightheartedness, but also the concept of feeling important, because all this project has are realized with the involvement of our professionals, and so in a time that is not easy for them, it's a critical time of their life, the self-esteem may be deeply damaged. I think it's important to give them the opportunity to feel important and to regain a sense of future, because we know that the cancer make our adolescent patients to abandon any plans, drastically change the way they think about the futures. The future became the time when they are discharged from the hospital on the start of the next cycle of chemotherapy. And if you have a project that are long, and we started to think about a project that will be finished at the Christmas time, and you are in May, in June, you have the idea of a different idea of the future and the end of the horizon. And then, as I said, the opportunity to express themselves more freely. I think that is very, very important that for our patients that they have the opportunity to tell their story, first to themselves and then to the others. And talking about the disease, talking about how they feel is of great importance in the process of elaboration of the trauma, of the cancer diagnosis and the end of the therapy, in order to find the inner resources to answer to the question, why me? And these projects are very important for us as doctors because they give us the opportunity to have a precious window of the inner world of our patients. Sometimes our patients communicate more with a picture, with a song, with a poem, that with a real conventional method of providing psychosocial sample. And then talking about the cell, we say, but also about talking to the community. Our patient became testimonials, and this is very important because many times ago, I remember a meeting, it was in 2006, Ronnie Barr, that is one of the father of the EYA oncology, when we ask some tips, he say, okay, find a good testimonial for your project, because it's important that the people, that community, that the newspaper became aware of the challenge of EYA patients. And I think that it's important to have a famous testimonial. It's important also that our patient became the real testimonial for the project, working side by side with the physician. And you can see in this slide some of the different newspaper articles that were published over this year, talking about our project in the Your project, but talking also about, you talk about the song, and at the same time you talk about the problem of accessibility to clinical trial, for example. And the last aspect is this one. This is a sentence by Camilla, it's a girl with an osteosarcoma, that say how this project was important for her, but how also this project may have the concept of science of the soul, because one of the major aspects is that we were able in this year to publish the story of all these project. You can find this publication on PubMed very easily. Some are published also in very high level journal, and this is a sort of recognition by the scientific community how it's important to give our patient their voice, how it's important to start also to think into a new way of a sort of new literature when we use the picture, the smiles, the direct words of our patients. You can see here some very beautiful picture from this project. And this was the last one. I was only 16. We did not already publish the article, the scientific article. You can find on the internet. This is a song written in English directly by our patients to reach a larger audience, and you can find, of course, in YouTube. Last point, very quickly, the concept of sustainability, funding, governance. I think this is very important because the sustainability is really a challenge. It was a challenge when we started to discuss about this point 15 years ago. It's still a challenge because it is not easy to demonstrate the value of AYA dedicated program. Our hospital are, in any case, some public administrative places, at least in Italy. We have many problems of prioritization, of cost. Funding are many times, at least in Italy, as I said, based on charities, on the philanthropic support. And this cannot be enough because sustainability may be done only if the concept way AYA specific program, the concept way a dedicated model of care may be accepted as a standard of care at a governmental level. This was a publication some years ago when we tried to list some metrics to try to demonstrate to our administration that our project was important, because it is not enough to say that our patients are happy about the project. It's important to try to show them, and it's very difficult to demonstrate that we can increase the overall survival of the patients, of course, at least in a short, medium period. And so we need to try to understand for them how it's important, the growth of the number of AYA patients seen in the unit, the proportion of the AYA patient enrolled in clinical trials, the proportion of the patient that receive fertility or psychological support or participating to the activity, and maybe show them research and show them publication, and show them how we can increase the impact factor with publication in AYA. Because again, I think that each AYA program should find each local way to become sustainable over the years, over the time. This is a really important point. I think it was my last slide, and so thank you for the attention.